I would like to welcome everybody to the Africa Science Media Center press briefing coming to us from Kampala, Uganda. We are lucky to have Dr. Monica Musenero Masanza, who is a very experienced doctor in Africa and of course globally. But in terms of her brief, very brief background or bio, Dr. Musenero is currently the Senior Presidential Advisor on Epidemics and one of the key players in Uganda's response to the COVID-19 pandemic. She is also the chair and team leader of the Presidential Scientific Initiative on the Epidemics, which is titled PRESIDE, a recently commissioned scientific think tank and coordinating platform set up by the President of the Republic of Uganda to fast-track scientific research leading to the production of epidemic response tools, including vaccines, diagnostics, and therapeutics. She has worked with several organizations, including WHO, as part of the field team that brought the Ebola outbreak in West Africa, including Sierra Leone. She has served as technical advisor for the USAID-funded One Health Workforce Program. Dr. Musenero is an alumni of Cornell University, I think one of the best in the world, which is based in Ithaca, USA, and the Makerere University, also well-renowned, Kampala, Uganda. She was recently appointed to the cabinet as Minister in the Office of the President in charge of Science, Technology, and Innovation. Dr. Monica, we are really very glad that you found time to join us so that you can discuss with this very important subject. You will also tell us briefly about the work that you're doing in Uganda, the new initiative, because discussions around COVID-19 also involves how Africa can produce its own vaccine, not just for COVID, but also others. But of course, now COVID is the emergency that we have, that when we hope you'll be telling us what is the country planning and how is it working with the larger Africa region so that Africa can also have its pride on place in terms of producing its own vaccines. But most so, of course, Uganda has been in the news about this COVID, very depressing news in terms of the spike of COVID infections. And we'd like to hear from you. I think nobody else can give us a better talk to the journalists in terms of really what is happening on the ground and what is being done. We are more interested actually in what is being done to bring the situation under control, because that is what people would like to hear. We as Science Africa, the Africa Science Media Center, and a number of the journalists who are here are very interested in the solutions rather than the problem. So thank you very much, Daktari, and you're most welcome to address us. Then after you're through, then we can you can allow a few minutes for questions that the journalists will have so that you can address them. And then just to let you know that this meeting is recorded and it will be shared widely globally through the web, through the online media. We have Science Africa, and many others also use now multimedia systems. And we also have the AfriSMC portal where this is going to be placed. So thank you very much, Daktari, and you're most welcome to address us.
Can I confirm that you hear me well?
Yes, we can hear you.
Okay,
Yes.
Please, if there is a break, we have had a bit of trouble with our internet. So if you don't hear me well, alert us so that we can make sure that you are getting the best signal. So thank you very much for inviting me to address you on this day. I'll be addressing on four major specific areas in the different capacities. First, as part of the intersectoral committee, the technical intersectoral committee, which is the committee which has oversight over all the response systems delegated by the president. So we do the technical work, and I and my co-chair, we lead that. Then I'll be addressing you on the government efforts, the different sectors which they are doing. And then I will address you on the private sector. What is the private sector doing? And finally, what the community is doing. I thank you for pegging your interest in what is happening. As you all know, Uganda, like all other countries in the world, we have been battling COVID. And we were one of the countries that managed to delay the entry of the virus. And when the virus entered, we were able to delay its entry into the community. We had a lot of imported cases that we did not allow to infect other people. Eventually, when we had the community transmission, we were able to apply public health measures, and we limited it. However, like COVID will be, starting around August last year, we had the first spike come, and we had actually been able to avert deaths, and we had the first. Can I share a screen?
Yes, we can see it. Yes.
Okay, so this epidemic curve reflects more the impact of control measures at these different stages of the epidemic. And as you can see, we have a long tail, then we had a spike as the first wave, we went down, and as you can see, we are climbing very sharply on that zigzag, more reflective of the incubation periods. And so over the past few weeks, we don't have very good indicators. However, because of that, we have ramped up the measures which we are putting in place. And I will share the measures in terms of, as I outlined. First, because we have recognized that this situation is getting out of control, we are reaching the peak of our carrying capacity. Mortality is rising, and the spread is quite diffuse, although it's more intense in the cities, especially in Kampala. But the reports we have really show some intensive spread in many other parts of the country. So the government, starting about 3 weeks ago, we have put in place measures, one, to limit the spread. Those measures started with a presidential address to the nation to remind them. They've been followed by intensive discussions by the National Task Force. And on Sunday 16th, the president addressed the nation and put in place containment measures to limit the spread, which were to be reviewed and either upscaled or downscaled, depending on the response. He put in place that committee I told you about to make sure that the measures are being monitored. And these measures are aimed at limiting community spread. So we have limitations on transport, people movement across the nation. Although in each district people are moving, we have a limitation on moving from one district to the other. We have intensive enforcement of SOPs in public transport. We have closed down mass gatherings of any type, and many offices are working at 30% capacity. Now, those measures are to be reviewed. They have actually undergone technical review, and we expect to revise those measures. It's too early for us to tell whether the measures are going to have an impact on the epidemic curve. It's too early to tell. We need to see the at least the incubation cycles in order for us to see the impact. But Kampala is sparsely populated now. We still have a few areas where the population is not observing the social distancing sufficiently, and those are being trying to enforce. The community has responded very well because now the reality of COVID is on everyone. So they have responded to the call, especially in the urban areas. We are still assessing the response in the distant.
Sorry, we are losing you. We have lost you. Hello. It's gone. Sorry, we have lost Terry, but I'm sure she will rejoin. Let's just give her a few minutes.
Hello. Hello.
Hello.
Hello.
Hello.
Hello, yes, we can hear you.
Sorry, we have an interruption.
Yes, we noted that. Welcome back.
So I have to address you verbally until we sort out. There is a problem with our network, which we have been trying to solve. So let me address you now. I'm using a phone, so I'm not able to show you most of the graphics that I had prepared. So what I was saying is that we have the measures which have been put in place. Right now, we have what we call a partial lockdown throughout the country. We are reviewing to see compliance on that. And then we expect revised measures in case we find that what we have is not working. In terms of making sure the medical responses, we have also over the past week undertaken a serious review of the interventions to make sure that there is testing, identifying cases very early, and they are tested throughout the country, bringing the testing close to the people for early identification of cases. There is ongoing efforts to make sure that all districts have enhanced capacity to detect cases and respond. There are efforts ongoing to scale up hospital capacity and to make sure that, like, we put up auxiliary facilities to manage the overflow, which we were expecting. So there is efforts to expand capacity. There are specific medical interventions or logistics, which we are experiencing close to shortage, especially oxygen. Oxygen supply is close to overrunning. We had since the epidemic started, really increased the capacity to produce oxygen within the country. So we have brought many stakeholders, and we are even trying to link up with the neighboring countries if they can help us with the oxygen, temporarily oxygen boosting cylinders and the production and supply systems to make sure that we can save as many people as possible. We have also revised the home care package to make sure that individuals who are at home, because since last year we put the home care as especially for mild and moderate cases, we have official guidelines, but we have noted that individuals who should not be in home care keep staying in home care, and by the time they enter the formal care system, they are a little too sick. So there is a monitoring system which has been deployed now to make sure that people are checked on and they can enter the official care system in time. To make sure that we ramp up both the treatment supplies, but also vaccination, the private sector has mobilized itself, and we have linked up with the private sector to utilize their oxygen production systems and private sector, private hospitals to provide care. So there is a lot of effort to really mitigate where we have the field interventions to reduce the flow of cases into the hospitals. We are also ramped up efforts to make sure that those who come to the hospital are able to be treated and cases are found early, and so that we reduce the mortality. The private sector is also coming together with government. We are ramping up efforts to make sure that we obtain more vaccines and we are able to vaccinate. So we are working intensely to make sure that we can access vaccines as quickly as possible and start vaccination to increase the immunity among the population. We have also, over time, we had developed a community engagement strategy where we can deliver and engage the community, both for identification of those who are sick, for rapid referral, for community-based surveillance. We had developed and optimized the system, so it has been deployed, both for education, for communication as a community intervention to reduce transmission, but also as a system to assist those who are infected to access care quickly, those who are in home care to receive information which they need and be supported. And we also have community-based organizations. The civil society has come on board to help provide relief or humanitarian support to individuals who may be sick. They are in home care. They may be there, but they don't have food. They don't have someone to send to purchase. So those are some of the efforts that are currently ongoing. We have ramped up communication on all levels because we have realized that COVID has a very, very serious social impact on both the community and also the patients. The sufferers get depressed, and that makes them deteriorate, especially as they observe others die. But also the fear, there is a negative effect of the fear in the community that paralyzes and depresses people. So we have put up that community intervention. So in summary, that's what we're doing. We are responding. We believe that they are going to push down life, and it's also going to push down the deaths. Thank you.
All right, thank you very much, Dr. Musenero, for that, the highlight you have given us about the responses that are being provided by the government in a concerted way, together with the communities, civil society, private sector, and I think almost everybody else in Uganda to bring this under control. What I've not heard, which maybe you can comment on briefly, is what is the status currently in terms of the infection, and what is making this go up? Like, is it the variant, or if it is the variant, which one is it?
We have a mixture. We have a mixture of strains. What we suspect, we are undertaking a serious investigation starting this week. By next week, we'll have an answer. What really, because this crept on us very suddenly, but some of the things that we have seen is last year we made a decision to allow partial and staggered opening of schools. We opened schools and allowed especially candidate classes across all levels to go back to school. As we went on, I think we slowed a bit on surveillance in what was going on in the schools, and many more students came into the school system than we had allowed. So we started observing clusters and seeing students who shouldn't be in school already in school. And I think that is part that we had more congestion in schools than had been allowed. So the school system across the board, I think they became distribution centers as children would come to school and go back home and interacted. So that became an amplifier. We have observed that in across the education system, from primary schools to secondary schools. Secondly, we had clusters of the community that chose to abandon the SOPs and engaged specifically in some very specific super spreader activities. By the time we started seeing cases and going on enhanced enforcement, the damage had already been done, because we were tipped off when we were beginning to see a lot of cases in the corporate the young corporates in banks, in government offices, in business offices, and that category of people are dominating those in the hospital. So we realized there was something going wrong. These guys were getting infected somewhere. So, and now those people have young families. So we started seeing children. You know, before we did not see so many children seeking, being sick enough to want to be admitted, to need admission. And we started seeing children, and that tipped us off. And we started the enhancement of enforcement, but we closed the schools, but it was a little too late. So you know how COVID amplifies. So we now have started to ramp up to make sure that we mitigate the effects of these breaches in SOPs.
Okay, thank you very much for that. Let's open for questions. And yes, questions and comments. If you have, please unmute and ask your question. You can also use the chat to write it. Dr. If you're able to access the chat, you can check it, or I will look through the chat and read out some of the questions for you. The floor is open, colleagues.
Thank you very much.
Okay, Esther, go ahead.
Thank you very much, Dr. Musenero. As usual, we really pride in you and thank you for the knowledge you're sharing. My question is about the private sector. We know that the government of Uganda agreed for the private sector to be a player in the vaccination strategy of this country, unlike other countries. But we also know that we have had some issues of the private sector actually not doing the right thing. So we want to know whether government will still allow the private sector to play a role in importation of vaccines and distribution of COVID-19 vaccines in Uganda. My other question is about the excess deaths that are being recorded and which you talked about. Somehow the figures that we are getting from the ministry or the official figures from the government are not tallying with what we are seeing from the community. Can you kindly comment about that? And can we clarify about the variants in the country? Don't you think that we have one variant that is running around and causing a spike? I mean, the schools could be a problem, but isn't the variant also an issue? Thank you very much.
How are you doing it? Should I answer each set of questions as they come?
Yes, I wanted to think that those are three questions. Maybe you can answer those ones. Then we take the next round. If one asks one question, then we ask the others to ask. We have like three questions before you respond. Thank you.
Okay, thank you very much. The issue of vaccines in the public sector, in the private sector, and the discussions and the fears which are there. Many are valid, but they should not completely prevent the bringing together of strengths. Private sector has their strengths, government has their strengths. So what we are seeking is to harness the strengths from each of these sectors and bringing it together. So there is a working group which has been put in place, which is now working in a concerted manner together with UNICEF, World Health Organization, so that although the private sector has their advantages, they can bring in things very fast, they can, but also because there are some issues with the quality, with the safety, with the ensuring. So instead of working alone, we are trying to bring together a team, to bring together the strength and harness the strength of each of these entities. And these discussions are ongoing. So government will come together with the private sector, together with our international regulators, and work out a system which will make sure that we do not miss on the advantages of each of these. Excess deaths, yes, we have recognized and we know the cause and the source of the discordancy in information, because one, when individuals die, when they are tested and they are under home care, or sometimes they are in the private facilities, the information does not automatically trickle to the database. So they will die, the public and the press will know, but in the Ministry of Health reports what's in the database. We have also had issues where by the time individuals get into the healthcare system, they have symptoms of COVID, but when we test them by that time, they are negative. They are negative because the stage of the disease will make them negative. It's not because they are not COVID. So we have but the database has to first make sure that that is a COVID case. So there is a slight lag. There will continuously be a lag in the data that you feel are the deaths happening and in the data which the Ministry of Health and the World Health Organization have, because the data has to go through cleaning, but also you will know that there are community deaths that you will not capture, that the community may know. People are tested, they go back home, they die there. So although we have them in the database that they are tested positive, we don't have the information that they have died. We are taking a survey soon to make sure that we can clean up the database, collect information about community deaths on those that have appeared in the database. But you also know that there will be people who will die and they were neither tested and or confirmed, so they're not even in the database. So it's not a deliberate effort to not provide data, but it's more of we want to give you information about this, from data which has been confirmed. The Ministry of Health has just completed a process to redefine the case definition. So you will now be seeing an additional piece of information, because what they have been reporting is only confirmed deaths. Now they'll start reporting probable deaths. Those are individuals who died. We think they died of COVID, but we still have to verify, or we may never verify, but we suspect there's information which is suspected, but we do not have a confirmed PCR test in the database. That will be more indicative of what's happening in the country. Variants, the government undertakes running of variants, and at the last report, we had a mixture of variants. We have a mixture of all sorts of variants. We have the Kampala variant, we have the Indian variant, we have the South Africa variant. We have a mixture of them. We have a mixture of different variants in the country. We have not yet seen a relationship, but Uganda Virus Institute is running a new set of sequencing. It's a process, takes a little bit of time, and possibly this week we'll get a new profile.
Yes, I see Eunice. Java, you have your hands up. Eunice, the floor is yours.
Hey, Kenya. I have a question for Dr. She had mentioned earlier on that they have noticed a rise in the number of students who are seeking medical attention at the hospital due to COVID-19. Perhaps if she can tell us if the number is worrying at the moment, and what are they doing in terms of, vaccination of the teachers and people who come in contact with the students in schools. Then number two, she's mentioned that Kampala, or rather Uganda, is facing all these variants, a mixture of variants. Are there any talks that they have with neighboring countries like Kenya, Tanzania, in terms of mitigating the spread of these variants to the other borders? Thank you.
Okay, let's take one more. We take one more from Jael, then then Dr. can answer.
Hello, my question is, what age group has been affected by the deaths? Because at the beginning of this wave, we saw that it's the youth that were greatly affected. Is it the same in the number of deaths, or is it a different age group? Then my second question is, we have noticed the medical charges are a little high. For example, in Mulago, one has to has to pay for their medical charge, then they have to pay 1.2 for their body, then they have to pay 4 million for the burial without transport charges and the casket. Is there any form of regulation in these charges? And then it is more in the private hospitals. Yeah, those are my questions.
Can I seek clarification on that question before you go? You're saying there are charges in Mulago? Mulago, the government?
A mother-in-law, my brother's mother-in-law passed away recently, and they had to pay for the mortuary 1.2 after paying for the medical expense. Then they were asked for 4 million for the people who had to move with the casket, those guys that put on the white things. And then, you know, they have the other expenses of transport, then the casket, things like that.
Okay. Okay, should I answer this first?
Yes, please answer the four that have been asked. The first one about the teachers, and then the other two.
Okay, thank you very much. From UNIS, the students, we closed schools. We closed all schools, and unfortunately, it appeared that because we thought this was a rising, after closing and doing a bit of investigation, we had more infection rates than we had suspected or we had monitored from the surveillance. So we closed all schools. All educational institutions are closed. And we have advised all parents and families to make sure they test their children. They can test at the nearest testing center. If the children have COVID, there are treatments which are given. Fortunately, we have not seen a lot of deaths in this age group, although they were infected. Some of them who are infected, they have fallen sick quite seriously, but we haven't seen, we have one confirmed death. We haven't seen a lot of deaths in the children in schools. However, we have seen deaths in the other categories. Our teachers were among the priority groups for vaccination in Uganda. When we got our first batch of vaccine, they had been prioritized. However, much as they were offered the vaccination, you all know what has happened in all our countries, that the anti-vaxxer messages really delayed the uptake of vaccine. So a number of our teachers have been vaccinated, but they have received only one shot because the vaccine which we had received in March was going to expire in July. And as we kept, trying to, the trickle was starting slowly, which is what has been all over the world. There was vaccine hesitancy. However, by the time they picked up, it was a little late, and we opened up the vaccination to other age groups. So many teachers who are vaccinated have got one shot. There are quite a lot of teachers who are not vaccinated, but the government has now made it mandatory for teachers to return to, if you want to return to teaching, you should present a vaccination certificate, because you are both a danger to your children and the children may be a danger to you. So as a public health measure, that has been put in place. It will be a precondition because we have to live with COVID for a while, and vaccination is one of the interventions that we have. In terms of mitigating borders, East African community and first, the World Health Organization shares all this information with all the different offices in the region. So this information is available to all the countries in the region. They know what's going on in Uganda. But these variants have been reported in many of the countries already, even before they were reported in Uganda. So the chances that they will come into our neighboring countries from Uganda are limited. These variants are already there. They were reported in most of the neighboring countries before that. Uganda has, we manage, we have not closed the airport. However, we test everybody who comes in through the airport. you have to be subjected to a PCR test. It does not matter whether you're vaccinated or you have a PCR result from wherever you're coming from. We do a PCR test. This came from an experience. Okay, so I was telling you that as part of the control of entry of new variants, but also of introduction of clusters in the areas we don't know, anybody, Ugandan or foreigner from those countries which are allowed, we have to do a PCR test from the airport. And the mechanism has been running for a while and it works very well. There's a mandatory PCR test for anybody entering through the airports. And for you to board from Uganda to go to any country globally, you must have a valid PCR test. Whereas we can use antigen test for other measures, we do not accept that for travel. So that will help to mitigate Uganda as a source of infection of new variants to other countries. We do the same at the borders. Anybody who is entering through the land borders, they are subjected to a PCR test. And then they are followed up if they turn out positive, and the measures, the control measures are taken on. So then the age groups, in the first wave, we had late age groups, above 50, we are the most at risk of severe disease. We still have that category. They still get those who are infected. However, because they were among the first priorities for vaccination, their contribution to the current epidemic is lower, especially those who took up the vaccination. We still have some, but not as many as we had in the first wave. The dominancy by these age groups, the young corporates, that's what I was saying earlier, whom we suspect had some risky something. There must have been a cluster that engaged in risky behavior. Then as they went to offices, they infected their colleagues. So right now, that group dominates the severe and critical patients, which is sad because it's out of that age group that we see a lot of deaths. So we are seeing not very young, but we see deaths among 19 to 29-year-old, and also 29 to 30 to 39-year-olds. That mortality is actually quite high because there are very many of them. Most of the deaths, okay, in terms of numbers, not in terms of mortality for this age specific, but in terms of numbers, we have a lot of deaths between the 25 and 45 age category, and they also dominate the critical, the severe and critical. We still have the other age groups. They are also there, and their case fatality in terms of age specific is still high, but in terms of numbers of who is actually dying, we are seeing more younger people. And it's because of the exposure. They are more highly exposed now, and we also know that there are more numbers of that group than the older group. When you look at our population distribution in Africa, we have more younger people than the older ones. So that is still happening. We have a lot of them in home care. We have a lot of them in the hospitals. Then about the charges, I think that's something that you're giving me information to investigate, because to the best of my knowledge, the care, there may be some medicines which we may not have, which we ask people to pay, to buy for their patients, because we are totally overwhelmed. But Mulago does not charge care, does not charge patients. It's a government hospital, and this is a public health measure. And government of Uganda does not charge people when we are in an epidemic for cases suffering from an epidemic. I know that there has been an outcry about private healthcare charges, and government is looking into them. We're trying to balance the policy of liberalization and leaving the private sector to determine their prices according to demand. But given that now it's a public health issue, the private sector has been engaged, and the Ministry of Health is working them to see if we can make this actually more humanist, more humanistic. You cannot start charging 60 million because COVID cases stay for long, especially if they went into intensive care units to make healthcare accessible to as many people as possible. But the issue of Mulago, that's an issue I'm going to take up and investigate and see whether those allegations are actually true and factual. Maybe you can get back to me later and we'll provide that information.
Okay, thank you, Dr. One more thing, as we look around for any raised hands,
Doctor,
the issue of vaccine.
Hello?
Just 1 minute, Ronald. You are next.
Okay.
Just wanted clarification based on the vaccine. The issue of vaccine hesitancy in Uganda, I understand, was quite high, and you had vaccines, and not many people are willing to get it. I don't know how that is being addressed so that going forward it will not be a major issue. And secondly, up to now, what is the percentage of Ugandans that are fully vaccinated and those who are half vaccinated? Okay, Ronald.
Thank you so much, Daniel. My name is Ronald Musoke. I'm from the Independent magazine. My question to Dr. Monica about those things. One is about, I think she has mentioned a range of spreader events, which she says could explain the recent upsurge in cases. But one thing I think I noticed is she didn't mention about the political campaigns which will happen between November and let's say February. So many people were against the idea of the country going to these elections, but you went ahead and advised, I think, the president. What was the basis of this? Upon which scientific basis did you advise the president on going ahead with these campaigns? And then quickly followed up with that is the recent swearing-in ceremony. You allowed 4,000 people to congregate in the midst of a pandemic, to congregate and witness this swearing-in of the president. Something happened in at the leadership institute in Chankwanzi, where you allowed in people, or you advised at least, I take it that you advised the president to go ahead with these large crowds of people to gather. These are some of the cases I think which you've not touched on, but some people consider they've also helped in the recent upsurge of cases. And finally, from me is the advice around the number of days you give. For instance, the recent presidential address, the president talked about 42 days, the partial lockdown. Upon which basis do you give this number of days? Like you want to lock down for 42 days, for 30 more days? What basis do you base on to tell the president to lock down the country for a specific number of days? Thank you.
Thank you. Please go ahead and respond. You're muted. Sorry, you're muted. Honorable, sorry, you're muted.
I wanted to cross to another gadget so I can answer these questions. Can they be asking some more questions so that I answer them once? I want to get back to the laptop so that I can explain to my colleague, my friend, why we make those decisions.
Okay, great. So do you have, I see Giles' hand is up, and we also have some questions on the chat, which we will review once Musenero is back.
So my question is there a way government could reduce the charges of the test? Because I have gotten friends who treated COVID, they actually thought they had COVID till after a period of 2 weeks when there was no change and they found out it wasn't COVID. But the fear they had was the charge that is taken while they test for COVID. So I was wondering if government has or is devising any means on these charges.
Okay, Elizabeth. Hello, Elizabeth, do you have a question?
I have a question.
Yes, go ahead and ask.
Okay, now
quickly.
I want
We are about
Dr.
to, just a 1
Musenero to
minute,
clarify
Elizabeth.
about the fee that is in charge during burial.
Elizabeth, you're breaking. We can't hear you. We can't hear you.
There's a certain amount of they are asking, especially majority of the people have Dr. Musenero answered the question when for treatment. The fees we were asking about were the fees about after the person asked 4 million shillings before they bury that person, bury the grave and all that. Then be in position to tell us delay of releasing results of those people tested is part of the super spreader, because people tested on Monday and their results are released on Wednesday morning or Tuesday in the night. Is part of super spreading effect. Thank you.
Dr. I don't know if you got the question, the whole of it. You can unmute.
There was interference in the first question.
Yes.
I couldn't hear all of it. If I only heard the parts clarifying that they are asking about fees for burial.
Which I think you had addressed.
Okay, then
no, she thought that the issue she addressed was about the fees charged when a person is sick. But the issue, the major issue now is about burial, 4 million shillings for burial, and in rural areas they are being asked for 2.5.
Yes, I think anyway, Dr. will talk, but I think she said she's going to address those together and investigate. Okay.
I don't know if the doctor got my question about reducing the charges on testing.
Yes, I did.
Okay.
Okay, then if you don't mind, maybe because I think these are related, I can see Jackie Chan, you can ask your question, then Lillian, then they can be responded to. We are just about to end the session.
Okay.
Good morning. Mine is about treatment, if I can call it that way, for COVID-19. We are getting vaccines that have been developed, but these vaccines are still being looked into to see how effective they are, much as we are getting them. Now, we've had people in the country, and the most recent case is the professor at Mbara University, who came up with Covidex, that is said to people have been using to treat themselves when they have when they suspect they have this virus. But there's been like the way he has been handled. It looks like he has been handled like so strongly by government, telling him to stop. But the question is, why are we using vaccines that are on trial, and then our local people who have remedies are being, pushed to the very edge because they have something that people are saying it works? So what does it take for government to actually support these local people who are trying to come up with remedies instead of, pushing them to the side? Because even the vaccines are on a trial phase, I want to believe so. So I wanted to hear what the minister has to say about that.
Okay, Lillian.
Thank you so much, Doctor. This is Lillian, and I work with AMREF Health Africa in Uganda. I head communications. I just wanted to get some clarity from Professor about the fact that the vaccines are currently out, and we know that today we are expecting a consignment. I think they said it should be the country by 11. How many doses are those? And for those of us who had already got the first vaccine, we based on the numbers that are coming in and the level of need, if we are not able to get the second vaccine within the stipulated time, what should we expect? What are the after effects of getting half dose? And how long should then one be able to either get the second dose or restart? Because some medicines, they say if you take so long without taking it, then you have to start the medication again. Is it the same with this vaccine? I just needed some clarity on that. Thank you so much.
Okay. Okay, thank you very much for these questions. And let me begin by, I have joined using a second gadget, so that which is showing the screen, but let me first answer the questions which don't need that screen explanation. The issue about the barriers of handling and taking the body out of the mortuary, I think, I don't know whether this is coming from the funeral services. Again, this is information I do not have a good handle on. So I will investigate to see. I got one report where the funeral services were asking for 7 million to be able to take the body. And because of that monopoly of being able to handle the COVID bodies, but we know that the Ministry of Health issued guidelines on burial of COVID victims. And those guidelines did not require that you have to have a special burial team. If the body has been treated and disinfected medically, that body was to be handed to the family with guidelines, and the family can get PPE and you can handle the body and do the burial. Actually, there's more risk about people gathering around that burial. There's more risk from the people who come to attend the burial than the dead body. So the people who come to attend the burial, so we have limited the number of people who attend the burial to only 20, because those are the people who are going to infect others. Actually, we have not had a lot of serious risk from the bodies themselves, but from the people attending the burials. They are the ones who infect other people. But the Ministry of Health, I will pass on this message. They will reissue those guidelines and avail them to the media so that the public is not, there is no extortion for, people have already faced COVID, and it has really stripped them financially. There is no need for people to be extorted at this stage. So I'm going to pass this information to the Ministry of Health so that the Director General can reissue the burial guidelines to the public. I do not have command of the figures being charged, and I don't like to speak about things that I am not very familiar with. Vaccine hesitancy, how was it handled? Vaccines, yes, please. Vaccine hesitancy, initially it was really, really bad, but towards the end now, we have more demand than we can give. And the policy guidance from the president is that we should focus on making sure that those people qualify, have a second dose, so that we have that, at least that proportion of the population who have their 2 doses. Initially, people hesitated, so by the time they rushed for vaccination, there wasn't enough time between the first dose and second dose and the expiry of the vaccine, because to avoid wasting this precious resource, we had to open up and allow everybody to come and take, everybody who is eligible, that's above 18 years. So we have a lot of people who have been vaccinated first dose, and they are going to be prioritized to receive the second dose if they have finished the 12 weeks. It had been lowered to 8 weeks, but we all know AstraZeneca, the best response is received if the second dose is given after the 12 weeks. Unlike the medicines which treat, this vaccine, if you pass 12 weeks after the first dose, it's not going to expire. It's not going to expire. When the vaccine comes in, you should go and take the vaccine and it will boost. The only challenge is that the first dose doesn't protect you very much, so you'll have a bit longer when you are still at higher risk. However, again, I want to reassure you, the government is working in a very, very urgent way and under pressure to make sure that we avail vaccination to as many Ugandans as possible. So be assured that although we had some hiccups, they are all efforts to make sure that the vaccine comes. So by the time, you won't have too long, unless you again have vaccine hesitancy, because many people didn't show up to get the vaccine. Now, I wanted to show something to my friend who is saying that the political campaigns. Now, when we look at our epidemic curve, sorry, it's ahead in this presentation. When we look at our epidemic curve for the country, when you have the virus spreads, and its what we call incubation period is 14 days. That's the average. From one infection, for me to become infectious to other people or to show symptoms, and generally people take 21 days from the time of infection to the time they lose. They are no longer infectious. They don't shed the virus. Around 14 days, you develop the symptoms. Between 10 to another 14 days, you will no longer be infectious from the time you show symptoms. So if there was an issue during the campaigns, all those people who got infected actually shed the virus. And the effect of the campaigns could only be seen in early January and February. But as you can see, we were able to conduct the campaigns. We had a period where there was a lot of defiance. And when we realized that the science that we had designed to govern the conduct of the campaigns safely was being violated, towards the end of the campaign, we banned campaigning in places where the virus was spreading fast. So those interventions led to actually a drop in cases, and we had, of course, weather change and we had a reduction in the spread of the virus. So the current surge is not related to political campaigns. We were guided by science of the virus, by the factors that lead to the spread of this. That's how we were, I and my colleagues, the science, we guided the president on how we can conduct. And if you see how the president was guided and how he conducted his campaigns, they were almost, they had zero risk to spread COVID. About the swearing in and about the Chankwan's event, we again use science. Everybody was subjected to a PCR test before 7 days before, and then they had a second PCR test just in case they were incubating the virus. It's only people who tested negative who went to Chankwan's. So there was no virus that went into Chankwan's. Now, risk is available if you have the virus in there. Before COVID came, people lived together. So if the virus is not, the people who are coming into camp do not have the virus, then there is zero risk. I wish we could replicate that nationally. We don't have enough testing to test everybody, but for those essential events which are being conducted now, including the swearing in, every single person who appeared at that swearing in had to be tested for COVID. Within the past 72 hours, they had to have been tested for COVID, and there were many who were positive. They were not allowed in there. Those whose results didn't come back, they were not allowed there. So it was a COVID sterile event with zero risk for spread of COVID. Moreover, we still insisted on social distancing. So it was scientifically set up. For normal national activities or normal community activities, it is not possible for you to achieve that because people will not comply. But there, the enforcement of those measures are available there. How have we guided? Why have we guided scientifically the 42 days? It is related to the incubation period and the time that people take when they have the virus. On average, from infection to when a person is clean, has lost the virus, it's about 21 days. So if we have put down measures which stop people infecting other people, we are taking the first 21 days. If those people should be clean, now this additional 21 days give opportunity to anybody who may have been infected, so that those people, even if they mix again after 42 days, they will have all shared of the virus. Unlike HIV, which stays in the person, COVID does not stay in the person. After 21 days on average, the person will be what we call sterile. They will be negative. So the chance that they will infect another person is zero. Reducing charges on the diagnostics, that's already in discussion, and there should be an announcement that will be made possibly this week about the cost of diagnostics in the country. We cannot control COVID if people cannot get tested. So there is a discussion that has been ongoing, which we expect to get some decisions made by the policymakers. The results being late is related to the volume of testing. We have testing centers in certain places. We have specimen collection centers. Then those specimens which are picked from the patients, they have to be transported. The machines have a capacity at which they run. The processes take time. There is a cycle which takes 4 hours. In some, we have machines which take 2 hours. So it is related to that. Then after results come out, they have to be sent to the entry center to avoid mistakes. We have to be careful when we are entering the results. There was a time when when people would kind of correct, give false results. So now the results come in anonymous. So it's only the person who aligns the results or the form and the results, so that we have a high level of accuracy of results. So that actually the time you have quoted is the ideal time for mass testing that we can get results. If you take your specimen on Monday, some people take it in the evening. If you suspect you have COVID, and since you don't have the results, please isolate yourself until your results come out on Wednesday, because most likely if you took that test in the afternoon, your results will be run in the night, then it will be sent to the entry center, then the results, the entry may be completed in the night. So that's when we start a lot of antigen testing, which is in plan. People will be able to get preliminary results very, almost instant, in 10 minutes. Really, where you go to test, they'll be able to run that antigen test and give you and tell you whether, if you're positive, you'll be taken as positive. But if you're negative, they'll tell you, okay, because we'll take it antigen and PCR. So for those who are negative. So then with that, you'll know something about your status. Either I am pending to get results on Monday, or I am positive now and I should be taking precaution. Now we talked the last question. I think we are running out of our time. The last question is about the vaccines and the drug COVID from Mbarara. I hope that I'll take this opportunity, and I really hope that you'll bring out this story. Please listen attentively to me about this story, because there are so many things which are running. I have all the facts, so I want to make sure that the public has the correct storyline. Vaccines which are being used, they are still on clinical trial, but they have undergone the animal trial phase, where we drew some information that they are safe and they likely deliver the results that we want. Then they went to phase 1 clinical trial, which is mostly to see if the vaccine is safe in human beings. They entered phase 2 clinical trial. Phase 2 clinical trial is when you test for efficacy. It could be 300, it could range from 80 to 500 people. You know it is safe. Now you are testing, is this efficacious? After phase 2 clinical trial, we go to phase 3 clinical trial, and this is when you put the medicine or vaccine to the public. And here, the results from your the animal trial, the phase 1, the phase 2, really have given you confidence that this vaccine is safe, or this drug is safe. And 2, there is some evidence that it actually does what it's supposed to do. And this evidence has been collected by not just you, the researcher, but other people. This information has been reviewed by regulators, because in such a situation, you cannot rule out that people will manipulate the public and either give them something harmful because the public is desperate, or give them something which doesn't work, but they'll still extort money. So because of that, there are strict regulations nationally and internationally to make sure that by the time you're told this vaccine works, there's evidence. No vaccine is released until sufficient information has been collected from a phase 3 clinical trial. At least the clinical trial has been started. It may not be complete, but it has evidence. And WHO does not approve any of those vaccines. You've seen that China vaccine just recently got validated, and Sputnik, the Russian, has also just recently got validated, although they were there early. So WHO could not say, use this, because we don't have evidence that it actually does what you claim. Now, when it comes to, so all the vaccines that we have, that we are going to get, that we are using, are vaccines that have at least that level of assurance. And that is why we even told you that it is by, you can refuse to receive it, but you will be at risk. So you are taking the risk. Now, when it comes to COVID, this is a very good researcher. We know him very well. We started to work, but when it came to this particular drug, he did his work alone. He has not shared his work with anybody. I remember they mentioned to study, to do some work on this particular, some herbal to treat. Actually, the only thing we all see is information online, and we see pictures of people lining to get a drug, and we don't have any information or which will assure us that this drug works. Science is designed in such a way that no single individual can claim that something works and does not convince a panel of other people that it works. We don't say you should, but you provide evidence. And in Uganda, we have levels. If you come and provide evidence, if he had written the clinical, those cases, and came to the National Council of Science and Technology and say, guys, I have this thing, it works. It seems to work, here is the evidence. Can you approve it for clinical trial and compassionate use? And then they'll go to the National Drug Authority and they'll give them authorization. But the National Drug Authority, the Pharmaceutical Council of Uganda, the National Council of Science and Technology, and PRESIDE, which coordinates all research on COVID, we all heard from social media. So we have no idea. We are not saying this is a bad drug, or it doesn't work, or it is harmful. We are saying, please bring the evidence, because we have a responsibility to protect the public. If somebody just puts, the way people are desperate now, you will fleece off the public, and we need to protect you. So we have not said that we are trashing this drug. Every single statement which has come out has said we are working with the scientists. And I personally have talked to the scientists, please bring the information so that we can assess it and see if it assures the public. Otherwise, right now, all of you are desperate. You will even rely on that thing and you don't seek care. So it can turn out to be harmful. So nobody is pushing local remedies. We are trying to promote the local remedies by making them scientifically proven and safe. So that is the story. We are working with the scientist, and if he brings the evidence, we are going to work with him. We'll even provide funding for him to take their medicines through a trial. We'll provide the connections to the patients who can be monitored so that other people other than him can tell us whether this drug works. Thank you.
Much. I think we have come to an end, and there are only two questions, very quick ones, that have been posted that I want to highlight. One is that it's about whether you are getting any help from any other country or neighboring country, especially on oxygen, for example. And connected to that is whether there is any guidelines on how communities in Uganda can use oxygen at home. Those are two. Then the third one is about which vaccine is Uganda planning to mix with AstraZeneca in case you don't have enough of supply of AstraZeneca. Very quickly, then we wind up.
Okay, thank you. Let me briefly address this. Yes, we are seeking help, and there will be official channels of communication if communication has already not been sent to neighboring countries to support Uganda with through this peak or with the high oxygen demand. We do not recommend people to use oxygen at home. If you need oxygen, at the lowest, you should be in the auxiliary facility. Any patient who needs oxygen should be moved to the health facility. This youth attempt for people to use oxygen at home has led to a spike in mortality. because oxygen is not just having a cylinder, and there are many other parameters that need to be monitored. You need to be in a place where you can be reviewed at least by an expert once a day or once every other day. So we do not recommend people to buy oxygen cylinders at home. If a patient needs oxygen, then that patient should be in the health facility, and the government is trying to make sure that they avail more space. If they just have other symptoms, they can be treated under home care. Please don't use oxygen. If you need oxygen, you should move to the health facility. Vaccines, which we are going to mix, we are attempting to complete the current people vaccinated with the same vaccine. We believe we'll get enough AstraZeneca to give a second dose. The doses that one of you mentioned, which are coming in, they are going to be given to those people who are getting the second dose, and we are also seeking more vaccines to AstraZeneca to make sure those people complete the second dose. However, for people who are yet to start the vaccination regime, it will depend. We are considering all the other vaccines where we have the technology to handle, especially Johnson & Johnson, Moderna, Sputnik, the Russian, and also the Chinese vaccine. It will depend on accessibility. The information about all of them has been reviewed and our ability to administer. So it's just the access. So depending on which vaccine we are able to get at the moment, we will also continue to seek AstraZeneca, but we'll try to make sure that an individual gets 2 doses of the same. Some vaccines require only one shot. So we will mix, and then we will strictly monitor and see which one has been more effective in the environment. But we have sufficient data from the studies to assure us.
Okay, thank you very much, Daktari. I can't find enough words to say thank you. I would like to call my colleague, Mr. Tulo Wur, if he's still there, to give a special thank you to you, and so that we finalize. But one more request is that this has been a very good update for all of us in the region, because the journalists here, some of them are from Kenya and different other countries, and we look forward to hosting you again to give us similar updates on the situation that is going on, because your knowledge is beyond what is happening in Uganda. It covers across Africa, and you can be able to give us really very good information in terms of how we can report on this evolving pandemic more effectively. Thank you very much. Mr. Tula, are you there?
Yes, I'm there.
Thank you.
Yes. First and foremost, I think I really thank Dr. Monica. There are very few scientists who communicate effectively the way she has done. And she really seems to know the weaknesses and the challenges the media face, the way she was clarifying some of the issues, the way she was using the charts. I really think we need to maintain contact with you. Any good journalist will make sure they have our number, because she's really, really thorough and gives information without anything remaining. Journalists are trained to be suspicious, but I've seen today, none of them seems to question what you say. You have opened up what they think was a black box, but as Mr. Tunge has said, the knowledge goes beyond the borders of Uganda. I think as Science Africa, we shall make a lot of effort to get in touch with you, so that journalists, the role have changed. We don't just cover politics. This is what is important to people's life: food, health, housing, basic human needs. And we have an expert here who has really, really given us very useful information in the most transparent way. I really thank everybody who has come, and our job is to do stories. We don't come here to listen and ferment the stories and do them a year later. So we expect a lot of effective communication to the public, because this is a matter of life and death. Otherwise, I thank everybody who has come. Thank you, Mr. Tunge, for what you have done. And again, Nakazi, my friend, thank you very much. And Dr. Thank you again. Bye-bye.
You are welcome. You are welcome. It's a pleasure to be invited to talk to you and provide information. I'm always available. You can always reach me through my assistant, whom you have been dealing with to organize this. Many times I will not receive your calls directly, but she will get the information to me.
Yes, Lydia has been very good to us. Thank you so much, Lydia. And Daktari, congratulations on your appointment. Thank you very much.
Thank you. I hope you'll be interested in science, technology, and innovation as you are interested in this course.
That is perfectly
Yes.
what we do. And we've done a lot of work with the former minister. I don't know if he's still in the cabinet, Dr. Elioda, CJ, who used to run the Minister for Science and Technology. We did a lot of work. So that is the area we operate in, and we would really, really want to work with you in different aspects, not just COVID only.
Okay, sure.
Thank you.
Okay, bye. Thank you.
Bye-bye. Bye, everybody.